Hi everyone, my name is Keshli Nubina. I'm studying at Kuala Lumpur Metropolitan University doing occupational therapy course. Here I'm going to present my case study for pediatric demography data. My patient name is H. His age is 5 years old. He born on 6th April of 2011 and he is a male, a Malay boy from KL, and also he is left-handed. His dominant hand is left-handed, and date of referral is 4 October 2016. And the purpose of reference is multi-purpose returning, and the is diagnosed is autism. Introduction. What is autism? Autism spectrum disorder (ASD) and autism are both general terms for a group of complex disorders of brain development. These disorders are characterized in various degrees by difficulty in social interaction, verbal and non-verbal communication, and repetitive behavior. Signs and symptoms of autism. Spoken language delays speech development. For example, speaking less than 50 words different than by the other age of 2 and not speaking at all. Frequently repetitions of set words and perhaps speech that sound very monotonous or flat, preferring to communicate using single word, being able to speak in sentence, respond to others, does not respond to their name being called, but having normal hearing, react unusual negative when asked to do something by someone else. Sign of symptom of autism. The third one is interacting with others. Not be able or aware of other people's personal space or picking unusual intolerance of people entering their own personal space. Little interest in interacting with other people, including children of a similar age, not enjoying the situation, but at the most children of their age, like such as birthday participants, preferring to play alone rather than asking others to play with them. Rarely use gesture or facial expression when communicating, and also avoid the eye contact. Their behavior are having a repetitive movement such as flapping their hands, rocking back and forth, or flicking their fingers, playing with the toys in a repetitive and unimagined ways, such as lining blocks up in order of size or color rather than using them to build something, preferring to have a similar routine and getting very upset if there are changes to the routine, have a strong like or dislike of certain food based on the structure and the color of the food, such as the like taste, unusual sensory interest. For example, children with autism spectrum disorder may objects or people inappropriately. Causes of autism. There is no single cause for autism spectrum disorder, but it is generally accepted that it is caused by abnormality in the brain structure or function. Brains can show different in the shape of and the structure of the brain in the children with autism compared to in a neurotypical children. Research do not know the exactly the causes of the autism, but are investigating a number of theories, including their links among their hereby genetic or medical problems. In many families, there appears to be a pattern of autism or related disability. Further supporting the theory in the disorder has been genetic basis. While no one gene has been identified as causing autism, research for regular segment of genetic code that children with autism may have inherited. It also appears that some children are born with a susceptibility to autism, but research have not yet identified a single trigger that causes autism to develop. Other research are investigating the possibility that under certain conditions, a cluster or unstable genes may interfere with the brain development, resulting autism. Still, other researchers are investigating the problems during pregnancy and delivery as well as environment factors such as viral infections or metabolic imbalance or explore of the chemicals. Personal history. Patient name is H. He is 5 years old. He's staying with his parents and good caring parents for him. They take him to the center daily without missing any days. He likes to eat crunchy food such so much. H easily people person because if his parents took his food or things, he let go also. And also he liked to hug and kiss from other to calm down himself as a reward to continue his work. Furthermore, if we focus him to do works means he will get angry on us so that we have calmed down him by hug him. He's very rare to sleep on time at night so that he came to the center with sleepy face. Even her sleep late, her mother still will send him to the center. His mother is very responsible person to look after his son. Family history. H have a parent, father and mother, and he has one younger brother. He is the elder, 5 years old. Social economic states. According to the patients, the family, the financial of the family is normal and no problem about supporting the children. His parents willing to pay for his therapy sessions and his school in the center. Medical history. Patient does not take any medications. Patient is good in general health and physically fit. Social history. H do not likes to make friends, even don't smile, always unpleasant face, no eye contact at all, always crying like when asked to eat over. H don't likes to eat fruits or vegetables in pre or probate and post probate. Nowadays, less crying. H likes to eat crunchy food, fruits, vegetable, crunchy all kind of food, and he likes to hug and kiss others. Educational. Presently, he's taking special education class at the school that's situated in therapy center. Evaluation. Subjective assessment. H likes to bite his t-shirt all the times until his shirt become a hole all and bad. He won't listen to mother instruction or sibling too. He don't likes to do any activity in center. He likes to eat junk food and pickle eater too. If he wants something, he will cry continually until that things get for him. He have a very weak muscle, and if he get angry, he will try to pinch and scratch us. Ob- Objective assessment. In objective assessment, the first part is occupational performance area. The in occupation performance area, going to observe in two areas, that is activities of daily living and instrumental of activities of daily living. To assess this area and area, the assessment that I use is school function assessment. School function assessment to assess the area and area. Here got the the assessment form that I assessed, and it is attached to the slide. You can have a look on it. The summary of the school function assessment to assess the ADL and IADL. Each can't perform well his activities of daily living or instrumental activities of daily living without prompts because he have a very weak muscle, so that he still need a prompts to carry out any activities. The second part of evaluation is occupation performance components. In occupation performance components, there are four areas, that is sensory, fine motor and gross motor, cognitive and psychosocial. For sensory, we use sensory profile assessment to assess the sensory, and P-body development motor scale to assess the fine and gross motor. Remove the school function assessment to assess the cognitive and psychosocial. Sensory profile assessment. The first, auditory processing. H can work with noise background. H enjoy the strangest noise and seek to make a noise but not too loud. Doesn't respond when name is called, but he know that is called, but and also the hearing is okay, just make do not and never bother on what we are saying. Visual processing. H becomes frustrated when place him in a dark place. He will try to get out from the dark room, and also he also becomes frustrated when trying to find things in competitive background is a messy background. Sure, he will like start to cry. Vestibular processing. He seeks all kind of movement, and this interferes with daily routine. Can't still sticks. He likes to rock unconsciously in chair during the classes. Oral sensory processing. H is a food picker eater, especially regarding the food structure, reward to crunchy. He shows strong preference for certain structure and taste food. He loves his orange juice so much because daily he will bring orange juice for center. Proprioception processing. Seek opportunity to fall without regards to personal safety. H take excessive risk during play, jumping from the swings just to escape from during exercise. Olfactory processing. Most of the time he smells his thing before use or use and food before eat. Summary of sensory processing. Olfactory seeker, tactile seeker, proprioception seeker, oral seeker, auditory seeker, vestibular seeker, and visual seeker. H is more to seeker behavior. He seeks for all kind of things. The second area of occupation performance component, fine motor and gross motor assessment is Peabody Development Motor Scale assessment. Peabody Development Motor Scale has 6 subsets to assess the client motor skill, but I use 4 subsets to measure my clients. The subsets that I use is stationary, locomotion, object manipulation, and grasping. Peabody Development Motor Scale, the first subset that I use stationary. This subset measures a child's ability to sustain control of his or her body within his center of gravity and certain equilibriums. H raw score for stationary is 26 and his age of stationary is 6 months. The second subset that I use is locomotion. This subset measures a child's ability to move from one place to another. The action measures include crawling, walking, running, hopping, and jumping forward. R H raw score for locomotion is 1 to 727, and his age of locomotion is 31 months. The third part of Peabody motor skill assessment is object manipulation. This subset measures a child's ability to manipulate the ball, for example, of the action measure including catching, throwing, and kicking, because these skills are not acquired until a child has reached the age of 11 months. This subset is only given to children aged 12 months and older. H raw score for object manipulation is 32, and its range of object manipulation is 38 months. The fourth subset is Prepsy. This subset measures a child's ability to use his or her hand, speaking with the ability to hold an object with one hand and progression up to action involving the controlled use of the fingers and both hands. H raw score for Prepsy is 42 and his age of Prepsy is 20 months. The third part of occupation performance components is the cognitive function. Assessment that I use is to assess the cognitive function is school function assessment. Here you all can have a look the assessment that I assess. Here I got a copy of attachment in my slide. Summary of cognitive school function assessment. H need prompts to remind him before his work where to place his things, where to do next, and etc. If not, he will just mirror around in the center without doing nothing and just avoid all the activities and doing parallel play. The fourth area of occupation performance areas is psychosocial assessment that we use is school function assessment. Is to say which I have to attach the assessment that I assessed. Here you all can have a look on it. Summary of psychosocial is H does not show any interest in making friends, even no eye contact at all. He can join the group activity with verbal prompt, but during in a group, he won't bother the group once his work is good, then may chances to participate in the group. If not, he will make annoying face, crying, and fall into problem identification. For occupation performance area, activities of daily living is unable to dressing. Sensory, cold concentration tolerance. Fine motor and gross motor is abnormal concentrate. Cognitive, unable to understand basic steps. Psychosocial is avoid group activity. The intervention, the treatment plan and goal for activities of daily living is short-term goal. H will be able to put on his t-shirt independently with verbal prompt in 1 month. In the long-term goal, H will be able to put on his long pant independently with partial prompt in 2 months. Treatment plan and goal for the sensory. Short-term goal is H will be able to decrease his frustration during self-activity, for example, swing, creeping, upside down, standing on the wall, with partial physical prompts in 1 month. Long-term goal, H will be able to tolerate his frustration with the pace and the burdens during self-activity, swimming, creeping, upside down, standing on the wall, with partial physical prompts in 3 months. Treatment plan and goal for fine and gross motor. Short-term goal, H will be able to improve his hand strengthening so that he will be able to form a pencil grip from static grip to dynamic grip in order a pencil in 3 months. He will be able to draw a vertical line, horizontal line, traveling independently in 3 months. Treatment plan and goal for the cognitive. Short-term goal, H will be able to understand of basic two-step instruction verbal prompts in 1 month. R will be able to put in his school bag inside a physio center cover independently once he enters the center. R will be able to put on his shoe in shoe rack not independently before entering the center. Long-term growth, H will be able to place back the material and tools, for example blocks, ball, books, color, pencil that belongs to the center that he used during the session time in 3 months with the programs. Treatment plan and goals for psychosocials. Short-term goals, H will be able to listen for at least 5 minutes in circle time in afternoon after lunch together with his school parents in 1 month. Long-term goal, H will be able to respond to close-ended questions yes or no appropriately to basic questions. He want to eat. Does he want to what now? Does he want to sleep? To his parent or sibling or therapist in 3 months with a sign of verbal bounce. Patient assets. Good financial support. Good family support. Parent good in comparing to the OT treatments. Model of practice. Preferred environment and occupation PO model. Through this model, it has been indicated that occupation performance results from the dynamic relationship between people, their occupation and goals, and the environment in which they live, work, and play. It is a client-centered approach but equal emphasis is placed on the environment and the occupation when designing intervention. PEO definition P. The dynamic and the changes with the skill and ability to grow over the time environment including the physical, social, culture and the factors that influence occupations. Occupation include the self-care, productivity and leisure. Frame of reference, cognitive frame of reference, assessing level of cognitive function and providing tasks appropriately to that level, aims to describe cognitive limitations caused by chronic illness, identify the remaining functional ability to the expectation of client and the realistics. Sensory integration frame of reference proposed to provide evaluation intervention designed to identification and prevent and remediate defects related to the child's sensory perception skill, motor and perceptive skill, sensory sensitivities, and related patterns of sensory functioning performance. These methods are used to achieve the overarching goals of occupational therapy to improve the client health and participation through the engagement in every activity or occupations. Rehabilitation frame of reference. The purpose of this frame of reference is independent in achieving through adaptive device and automated environment modification and virtual modification and visualization aids, adaptation procedures, and on safety education. The focus on this frame of reference is to enable the greatness among the independence for the person in safely and its timely manner competition in area, engaging in meaningful nature of occupations, having the needed skills. Developmental frame of reference. The developmental frame of reference is based on the theory of human development and across all like areas physical, cognitive, psychosocial, psychological, and emotional. Aims of developmental frame of reference is to identify the highest level motor and social cognitive skill in which a client can engage and facilitate improved function from the strategy points related activities so that the client can achieve them but inside these challenges help to close the gap in the area in which client is unable to perform. Humanistic frame of reference is concerned about the individual view of life or take a more holistic representative. In this frame of reference, changes occur through the relationship with our other and it seems inevitable to complement with treatments and utilize to successful rehabilitations. Biomechanical frame of reference. Key reference used in conjunction with various others in enabling the OT to assess and identify a client's occupation performed with various activities of daily living. Biomechanical looks into acquiring physical capacities such as movement, muscle strength, and endurance. Treatment implementation. Problem 1. Unable to dressing. The treatment that is given is training in ADL dressing. Target for the behavior is child will ever independently pull over efforts. Frame of reference that used for this problem is rehabilitation frame of reference, environmental frame of reference. The method and the condition that for undressing chaining is backward chaining that used to undress himself. The rationale is backward chaining allows a child to experience installs such as a small step to add and more competition. The nearly thought step immediately followed by the step she has already measured. This can be minimize anxiety and provide a child with a sensory expressions. Problem number 5. Avoid the group activity. Treatment, group play therapy, and group fun activity. Terminal target behavior to improve or increase the interest by joining a group activity. The frame of reference that is used for this problem is humanistic frame of reference, developmental frame of reference, and rehabilitation frame of reference. The condition method is child will able to sit appropriately, establish the high contact, engage in isolated type play, engage in social mimicry play, and appropriate actions, and participating in circle time after the lunch time together with peers in center. For the criteria is for 20 minutes. The rational social or the group activity is the integral part in our life. Activity become more important when the kids have more leisure time when they are grow up. Every day, the participation in different kind of activities include self-care tasks, play tasks, leisure activity. Program activity has specific goals where the participation is worth and can give happiness, meaningful activity, learning new things, and relaxing themselves, and increasing the social skill to other. The precaution is ensure the child is sit appropriately, enjoying the activity, and instruction that given is make sure is clear and simple. Treatment plan. Problem number 2. Poor frustration tolerance. The treatment that given is sensory integration therapy. The target behavior is increase the frustration tolerance. The frame of reference that used is sensory integration frame of reference, and the condition method is developing the coping strategy to deal with the frustration, requirement time and practice, and teach the stoplight with the deep breathings, simple craft activity, tabletop activities, to use Act 5 that work on the skill you are trying to build that are not actually the same as the skill itself. Rational is frustration tolerance can be increased by simple changing the way you thinking about things and others. Good frustration tolerance help to relax their self and help to calm down. The precaution is environment should be secure and free from the casual distractions. Problem number 3. Abnormal pencil grip. The treatment that given to this problem is position to preparing for gripping the pencil and writing. The terminal behavior is able to perform a proper pencil grip. The frame of reference that used for this problem is biomechanical frame of reference, developmental frame of reference, and rehabilitation frame of reference. The term and conditions that use is improve the muscle tones, improve the small muscle tone of hands, working in the vertical position helps to strengthening the whole hand, which is important foundation skill for writing. Heavy object activities develop the arm muscle like push-up, crab walks, and swimming in the base filter off. The criteria is for 30 minutes. Actual pressure grip can be used to help the child to achieve maturation. Effective grabs. It is important for child to develop a mature, effective pencil grasp by going through the developmental processes of reading pencil grasp. The precaution environment should be secure and free from casual distractions. Problem number 4. Unable to understand the basic steps. The treatment is knowledge the child about the simple step with modeling or with some prompts. The target behavior is able to understand the simple researcher steps. The frame of reference that used is the mental frame of reference and cognitive frame of reference. The condition to method is create a simple activity to develop the basic understanding steps. Cut all the activities that do every day. Give a reward when the complete any stops or even is not good enough. Encourage to do the books so that he can learn more steps. The caption is can do anytime and all the days. And the rationale is by applying the basic steps understanding, he can perform his works independently so that he can learn new things and more for his study. Understanding basic steps will increase will be graceful because he can perform any other activities. The precaution is ensure the child understanding way of doing and assist and supervise the child always ensure the instruction given are simple and clear. Home program encourage patient to do a practice in writing in home. Educate the caregiver about the dressing step to teach the child. Encourage the patient and the parents to do activity at wheelbarrow walk, push-ups, to strengthening the hands, educate the caregiver about some method to calm down the child when they get too active, and also a child will learn to communicate by watching and listening to their parents and they mimicking the words and action. The more you communicate with your child, the earlier, the quicker they will develop the skills. So the parents have to spend time to talk with his so that he can improve his communication skills. The future plan is to continue the treatment as above, to reassess the patient if possible, to visit back if possible, to visit back to some physio center again. Cognition rehabilitation are who miss appointment to come to occupation therapy are not able to follow the instructions given to her after the treatment sessions. Medical are also being newly start to try to say some words, some quick improvements. Reference. Thank you for listening and look on my presentation. Thank you so much.